Today I just got a brief talk on if ICU care improves post-op outcomes. I'm just going to start now, so I don't take too long. So this is a big cohort study. It's published in Anesthesia in 2024, and I'm quite interested to talk to you about it. This is what I'm going to talk to you about. So the structure of the talk is I'm going to talk about the trial and the results of it. And it was actually, sorry, it was a study, it wasn't actually a trial. But the main thing I want to talk about with this is actually the methodology. I want to talk a bit about directed acyclic graph, what that has to say about why randomized controlled trials are powerful, about causality criteria, and some conclusions about what we can take from all this. So it's a little bit different to a normal cast, and I do appreciate that normally we do that, but I've done one of those recently, and I thought this would be an interesting little segue to talk a little bit about a study with some quite interesting methodology instead. So the study was a pre-specified analysis of a cohort study. The study initially was called the SNAP2 study, and basically they took 2 weeks of theatre and kind of like ICU data, and they measured everything you could imagine, whether there were beds available, how sick the patients were, what surgeries they went for, all that sort of stuff was captured in this sort of 2-week study. And these guys went back in to reassess it, and their issue that they were wanting to address was, so in post-op patients, we don't know if ICU care improves morbidity and mortality outcomes. That's obviously a bit different, and we'll talk about some exclusion criteria from this study if they have like a definitive organ support need, like if they have neurosurgery or some like major vascular surgeries. But there's a lot of cases, and I guess like thinking about stuff with the LRI, like well, these are the sort of people that would have been included in this study as like the people that would have an APA. And we don't actually support an organ while they're here, and instead we justify their care here by saying that they get really good nursing support and really good nursing care. We can keep on top of their pain better. But that's the question: is ICU care actually better? Because there's no randomized controlled trials on this, and other data previously was quite uncertain. So we'll cut to the chase and say that the outcomes were that there were no clear improvement found in morbidity demonstrated by ICU versus core level care. But do remember that I'm not necessarily wanting to just talk about that today. And actually, the main thrust of what I want to talk about is about how they kind of got themselves there with their methodology. So these are the patients. I think it's quite important to get the patient population of who they were looking at, because yeah, like quite clear. So they had 26,000 people to start with. They only did first surgeries. They got rid of people who probably were already receiving high dependency level care from their population that we're going to study by excluding people in high acuity wards. That would kind of include like your resus patient that would go straight for an emergency laparotomy. They would be removed at that stage from the patient population that they wanted to study. They get rid of patients with absolute critical care indications. They were your big vascular, the big thoracic, those sorts of cases, or neurosurgery. We got rid of obstetric patients. I'm not quite sure why. I think they just didn't want the complication of having them in. It's not very clear. And they got rid of patients with rubbish data. So I want to talk about how they went about this study. They're trying to show, does ICU or ward-based care improve outcomes? And this is kind of like a graph of what they were doing. Now, in most normal studies, we take observed confounding variables. So these are things like age, sex, gender, surgical type, and we try and adjust for them. What we don't get in these studies are the unobserved confounding variables. They're things that, honestly, we never know. Like, there'll be like weird mutations that we don't know about that really affect a patient outcome, that we don't measure, but are actually really important. So in classic kind of cohort studies, the unobserved confounding is your reason you're worried about things like bias. your endogenous treatment variable for us that we're interested in at the moment is ICU or ward better? And then your dependent variable is your outcome. And in this case, they looked at like morbidity and mortality. Specifically, they looked at morbidity. Like, did they have like issues with their stay? Now, you're sat there and you're like, Tobias, so we keep talking about testing whether ICU or ward-based care is better. And there's been kind of cohort studies before where you kind of try and adjust for your observed confounding variables like age and sex. Well, the kind of neat thing that these guys did is that they used what's called an instrumental variable, okay, to try and randomize between ICU and ward-based care. What an instrumental variable is, and this graph kind of shows that these arrows are about time and causality. So an instrumental variable causes your treatment variable. So an instrumental variable in this case will be causing whether you go to ICU or critical care or to the ward after your operation, but it's not causing your dependent variable, which is your kind of like your outcome, your morbidity or your mortality. And by using this, you get that you have to bear with me is that I don't deeply understand the statistics behind it, but you can use this instrument variable, which isn't causing morbidity, to randomize people between these two things. And why that's powerful is then you get balanced cohorts and you adjust for the unobserved confounding variables as well as the observed ones. So what was their instrumental variable? How did they go about finding it? So they found it as availability of critical care beds at the time of surgery. And you can kind of debate whether it is a true instrumental variable or not. But what I want to talk about is just the interesting methodology that they've used in this study. So they used that as their instrumental variable, and it's a really good slide. The next slide will kind of explore that a bit more. All the other things you kind of would expect causing critical care admission, like age up to a certain level, having an operation on a weekend, surgical urgency, all these things were kind of correlated with critical care rather than ward-based care. So this is kind of like where they ended up with. This was like their, you call this a directed acyclic graph. And that critical care bed availability was causing whether you got admitted to critical care or the ward. It was a weak effect, but it was there, and it's enough to use the statistical test that they wanted to. But it's not directly causing morbidity and mortality. It's causing it through whether you admit to critical care or not, and that's really important. If I draw your attention and contrast that, if you have a look at patient factor, like age is a confounder. Age is causing both whether you go to critical care or the ward, and it's directly causing your morbidity or mortality. It's involved in that causal path. So that's really important. So that they use their critical care bed availability to randomize people, or pseudo-randomize, as they're called, natural experiments. People, and that helps account for unobserved confounding. And this hadn't been done before. That's why this was a good study. We've just looked before and tried to adjust for all these observed confounding variables. But this study tried to do something different, and it was quite elegant in the way it did it. So yeah, they used that. So I've got here, but they then used that instrument variable bed availability to this sort of 6 times and trying to label it so that hopefully it comes across okay. So this is kind of like the result, and I think this is quite interesting. So these are odds. It's an odds ratio of morbidity. So, and it's ward odds to ICU odds. Sorry, it's 5. So the odds ratio is 5. There's 5 times more morbidity going on if you're admitted to the ward than if you're admitted to the ICU. So the idea is that ICU care is probably better in the unadjusted regression near the bottom. When you get to the multi-level, multivariable regression, that's our classic adjust for all your age, sex, ethnicity, all that sort of thing. It sort of tends towards there maybe not being a difference. And then when you use their bivariate probit4 analysis, which is this natural experiment trying to randomize using an instrumental variable, yes, there's a wide confidence interval, and that would be clinically relevant if you're finding that there's a benefit or disadvantage still. but it's just this tendency to revert to the mean, to become one-to-one odds is really interesting. And so this is a little bit of light-hearted, really. But I laugh at that. I don't think anyone else will, but there we are. See how I understand it. So yeah, the risk of repeating itself too many times. They use bed availability, and this is not like other studies. Other studies haven't done this before. They use bed availability to try and avoid unobserved confounders. Now, I said I was going to talk a bit about randomized controlled trials. What relevance does this whole thing have to randomized controlled trials? The answer is that randomized controlled trials adjust for unobserved confounding variables through randomization, and that is the reason that they're powerful. Okay. So I'm just drawing that like similarity here between using this instrumental variable analysis tries to make what are otherwise muddy, messy cohort data into a pseudo-natural experiment, pseudo-randomized. It like introduces an element of fixing things that we just can't know about by balancing characteristics between the groups. And that means everything kind of neutralizes each other out, all of the unusual effects. But I got interested in all this sort of stuff and directed acyclic graphs and randomization from this book. So if anyone likes cause and effect and is interested in that sort of thing, this book's really good. Judea Pearl basically developed this field, and yeah, we'd recommend the book. It's quite like, it's kind of written a bit pop science, like kind of bestseller. So it's easy enough to read, but it is also quite detailed and like relevant for us as clinicians. It helps us understand causality in a muddy world, because it's particularly in intensive care, as we all know, can't run a trial and everything. And that's kind of, I'm going to talk about this in a moment, but this study I think is really cool, because you can't just randomize people to ICU or the ward after their operation because of feasibility and ethical issues. And the authors of this paper now say, well, maybe without even doing a randomized controlled trial, we now have, through their elegant trial design, study design, we maybe have some evidence to say, well, maybe it is ethical to give it a go and do a randomized controlled trial of this. Is ICU or ward-based care for post-operative patients better or not? And I'm going to wrap up, so I'll finish in a couple of minutes. If you haven't seen this, it's quite important. It's kind of like, this is how you assign causality. And I've been talking through this talk about like interesting methodology. You know, your randomized controlled trial kind of comes under experiment, whether experimental evidence supports the observational data. And if you have like a stonking RCT, you'll be quite confident in the causality. But the truth is actually, if you have a stonking RCT result, you've actually got you basically got all the other of these as well. You have, you'll not run an RCT without plausibility, without a plausible mechanism between exposure and outcome. One of the really important ones that's flagged up in Judea Pearl's book is about temporality, and it can be really easy to get time wrong, and get time courses of cause and effect wrong, and that's where the directed acyclic graphs can be really powerful techniques in epidemiology. And I used this and had a little think about John Snow's cholera fixing in London. And I think he demonstrated temporality. You know, he took away the pump handle, and then the cholera case got better. He had the plausibility. Think about like his germ theory. That was his biological plausibility reason he was doing it. Then he also had some experimental data. I mean, he wasn't in randomized controlled trials before and after trial. But we've had some of these Bradfield criteria, and we should always be thinking about how our studies, particularly things like cohort studies or observational ones, fit in and piece them together using these criteria. So yeah, this is the summary. Natural experimental methodology appeared to show that ICU care maybe didn't improve outcome of these post-op patients who didn't have a definitive need for ICU care. but there's still significant variance. But it was different to what we've seen before. DAGs can be really powerful in epidemiology, and in a complex world, you need to use the Hill criteria to support any sort of like causal paths or like assertions that you want to make. So yeah, elegant trial designs are possible and help solve difficult to answer problems. So maybe this trial will mean that we do RCT on ward versus ICU for post-op patients. Who knows? I don't know if they've got it in the pipeline. And then we'll gather the feedback set up later. Thanks very much. I don't know if anyone has any questions or if we move on to Rachan's talk.
Right, so for those of you who don't know me, my name is Rajni. I'm one of the consultants at the Glenfield Hospital. And this is a topic that I've been meaning to look up more as much for my own knowledge as it is to talk about it, because we've of late over the last few years, about maybe 2-3 years, we're seeing our patients turn up increasingly with new drugs that at least I didn't fully understand, and didn't fully understand the implications of having those patients present either to ICU or to theatres. So I thought I'd have a look at the drugs for heart failure, the new drugs that are being currently used for heart failure. So the goals for today's talk, really, I don't really want to talk about acute decompensated heart failure, or the kind of heart failure that we see in a cardiogenic shock that we see on ICUs, whether it is sepsis related or cardiogenic or whatever it is. I do not want to talk about that kind of an acute setting cardiac failure, where you would be talking about, say, inotropes or vasopressors and monitoring for thereof, that sort of a thing. This is really about chronic heart failure and the drugs that we encounter on patients who've been established on these new drugs. So that's what I really want to talk about. I'm also not going to talk about diagnosis of chronic heart failure. I'm not going to talk about the classification of heart failure these days, that is, preserved ejection fraction or mildly reduced or reduced ejection fraction heart failure, or the diagnosis of the biomarkers or any of those sort of things. I'm not going to be talking about any of that. What I'm really only going to focus on are the drugs that are currently used and the recommendations for the drugs. So whether it's the European Society of Cardiologists or the American Heart Association, what those current recommendations are, and have a look at those drugs. For me, my understanding of drugs is usually enhanced when I know the physiological process that they impact on. If I were to know that this particular drug works on this physiological pathway and it impacts it in such a way, then I'm then able to understand and apply that knowledge both on ICU and in theatres. So that's the reason why I only really want to focus on the drugs, and some of it would be useful for those of you who are sitting your primary or final FRCA or even FICUM, to actually get to understand how these drugs go. So currently, the current guidance or recommendations of heart failure is really based on these 4 categories of drugs. Okay, they call the 4 pillars of management of chronic heart failure. That's either ACE inhibitors, angiotensin receptor blockers, or angiotensin receptor neprilysin inhibitors. That comes as a class. The next group are beta blockers, and then mineralocorticoid receptor antagonists, i.e. spironolactone. And then the big thing are the SGLT2 inhibitors. That's really sprung massively on the scene right now, and we seem to be having more and more patients coming in with SGLT2 inhibitors, i.e. all the fluozins, dapagliflozin, empagliflozin, those sort of drugs. So they all seem to be coming in with those drugs. Now, for a number of years, ACE inhibitors and beta blockers, diuretics, they were really the, the three pillars of management. So, but now we've replaced some of these diuretics with mineralocorticoid antagonists because they're diuretics too. But then we've added in the SGLT2. So we now got this quadruple, strategy to manage cardiac failure, chronic cardiac failure. And then there are other things, we still have diuretics and we still have digoxin. I'm not really going to be talking about those two categories of drugs because I think, from med school, we've been learning about beta blockers, diuretics, and digoxin. So I'm not really going to focus on those drugs. The two new drugs, ivabradine and versigouat, which might hit our awards sometime soon. So we'll talk a little bit about those two drugs as well. So taking a deep dive in, so I'm going to just sort of give you a brief overview. I'm not going to go into any detail because, renin-angiotensin systems and everything else, again, from med school, really, isn't it? We've known them for a long, long time. And these drugs have been with us for decades now. So basically, the system is renin-angiotensin-aldosterone system. It's a sympathetic system. It's a neurohumoral system that kicks in response to drop in vascular tone, drop in cardiac output, drop in cardiac blood volume, cardiac output, and blood pressure. So the enzyme renin is secreted when in response to decreased efferent renal artery pressure. So that means that the pressure that is going to the kidneys is low, or there is decreased sodium and water delivery to the distal tubules, or there is sympathetic activation. So, stress response, a big surgery, a big critical illness, you have a big sympathetic stimuli activation. And your angiotensin-aldosterone system will kick in even in those situations, even if you might not be hypertensive, or even if you might not have reduced sodium and water being delivered to the distal tubule. So the process really is angiotensinogen that is then converted to angiotensin 1 by renin, and 1 is converted to 2 by angiotensin converting enzyme. Now, all of this system that maintains your blood pressure, blood volume, and cardiac output is counterbalanced by the next system that we'll also talk about. That's the natriuretic peptides. Okay. So again, just briefly going over these things again. So angiotensin 2, it maintains systemic vascular resistance via the angiotensin 2 or angiotensin 1 receptors, but mostly angiotensin 2, okay? It increases sodium reabsorption in the distal tubules. So that then leads to sodium and water retention. It stimulates the release of aldosterone from the renal cortex. So that's the mineralocorticoid. So that then, we're talking about aldosterone that acts to increase sodium and water retention. There's release of vasopressin that also results in water retention. There's stimulation of the third centers in the brain. But again, I don't know if you've noticed, we see this all the time on cardiac surgery, post-cardiac surgery patients, where you have, they're very thirsty the next day. They would have had about 3 or 4 liters. There might be 3 or 4 liters positive on paper, but they're still very thirsty. And that is because of the neurohumoral stress response that they're having. So again, they facilitate noradrenaline release, inhibit noradrenaline reuptake, therefore enhancing the sympathetic adrenergic function. It also stimulates cardiac muscles and causes vascular hypertrophy. And this is one of the pathophysiological features of cardiac failure, where you have, stiffened muscles, stiffened heart, and that in itself can give you some diastolic dysfunction. Okay, so Are you able to see the screens now? Okay, excellent. So again, talking about just sort of putting this again into context, you've got sympathetic stimulation, you've got hypertension and decreased sodium levels. So you then have renin increasing in the kidneys that stimulates renin to convert angiotensin to angiotensin 1 and 2, and that has all the effects that we've just spoken about. It's just a pictorial diagram of what we've just discussed. So again, this is all old medical school knowledge. You have ACE inhibitors and angiotensin receptor blockers. So the ACE inhibitors inhibit angiotensin converting enzyme and therefore inhibit the formation of angiotensin 2. You've got the direct blockers of angiotensin receptors themselves, and these have a better side effect profile because they're not, you're not having, because angiotensin converting enzyme, converts bradykinin as well. It breaks down bradykinin as well. So when you block that enzyme, then you've got increasing levels of bradykinin. And that's why with the older ACE inhibitors, you had cough and angioedema. So ARBs have a better side effect profile because of that. You've got a couple of examples of there. Now, again, we've spoken about the impact of renin, angiotensin, aldosterone systems. So the effects of their blockers is going to be the opposite, isn't it? So they're going to reduce arterial and venous tone, which then causes vasodilatation. It reduces ventricular afterload and preload. It decreases blood volume by natriuresis and diuresis, decreases sympathetic tone. So with all of these things, it would have a positive impact on cardiac failure, wouldn't it? Because you're reducing your edema, you're reducing your pulmonary edema, you're reducing your systemic edema, you're improving the preload, you're getting the preload onto a better part of the Frank-Starling curve, you're reducing afterload. So all of those things would help with cardiac failure. So again, as I said, reduced afterload improves your stroke volume and ejection fraction. There's a better oxygen supply demand balance and a reduction in sympathetic tone. Mineralocorticoid antagonists, again, medical school knowledge. Example, the hormone that we're trying to antagonize is aldosterone. It is released by the adrenal cortex in response to increased angiotensin 2. It increases sodium reabsorption in distal convoluted tubule in exchange for sodium and potassium, and therefore results in sodium and water retention. So if you have MRAs, for example, spironolactone, you then inhibit the sodium reabsorption, but it's a slightly better diuresis in the sense that you have potassium sparing effect of these drugs. So we now come to the next set of physiology within the RAS system, and this is the counterbalance to RAS. So natriuretic peptides, these are peptides which are synthesized by the heart, brain, and other tissues, and they're released in response to atrial or ventricular stretch, okay, or to neurohumoral response stimuli such as increased angiotensin 2, endothelin, or sympathetic stimulation. You have three types: atrial natriuretic peptide, B type, and C type. B type used to be called brain natriuretic peptide, but it's probably more accurate to call it B type. These, when you find these increasing levels of these peptides in patients, those are an indicator of biomarkers of cardiac failure. So if anything greater than, say, about, I think in Leicester we say 140, 135, 140, that would indicate impaired cardiac function. So the way they work is that they bind to the natriuretic peptide receptor A in vascular and renal tissues. This then couples to guanylyl cyclase, leads to the formation of cyclic GMP, which again, for those of you who are sitting your primary, is a second messenger, and it modulates vasodilatation. Okay, so RAS system causes vasoconstriction, natriuretic peptides cause vasodilatation. All right. So how is it metabolized? It's cleaved by an enzyme called neprilysin, and that cleaves it to inactive products. So neprilysin, if you then inhibit, it increases natriuretic peptides. So there's only one inhibitor now that is currently available, that's sacubitril. Now, this is now being marketed as a combination of sacubitril and valsartan. The name of that combination is Entresto. So that drug is now available as part of chronic cardiac failure management, whether it is reduced ejection fraction or mildly reduced or preserved as well. So it is available as one combination. That's the only combination that is available. They did have nesritide a few decade or so ago, which did not have a good enough safety profile. So we don't use nesritide anymore, but we do use Entresto. So you'll be seeing Entresto being prescribed for drugs or patients prescribed with Entresto pitching up on your wards on ICU or in theaters. So this is how it would work. So you would either have, if patients are already on ACE inhibitors or ARBs, then they probably stay on those, but patients who are naive, ACE inhibitors and ARBs naive, will probably go on to Entresto. Okay, so that's the first pillar that we have discussed up until now. Actually, we've discussed two. We've discussed mineralocorticoid, MRAs as well. So we've discussed RAS and mineralocorticoids. All right. So this is how it is broken down and how it sort of increases cyclic GMP from GTP and causes vasodilatation. So natriuretic peptides will cause just the opposite of what RAS would do. So they cause diuresis, natriuresis, improve GFR. They inhibit renin relase. They cause systemic vasodilatation, arterial hypertension, reduced venous pressure, and reduced wedge pressure. So if you were to have a Swan-Ganz N, you'll notice a reduced pulmonary capillary wedge pressures as well. So as a direct correlation, you might find that when you start patients on these drugs that they're a little bit hypertensive, and you would need to titrate that and take cognizance of that. So this is just a pictorial diagram of what that is. Okay. So the recommendation for RAS inhibitors and ARNIs is the trial paradigm heart failure trial. So as I said, sacubitril, valsartan combination compared much better than ACE inhibitors for quality of life, rates of heart failure, hospitalization, say acute hospitalization due to heart failure, and all-cause mortalities. Rates of hypokalemia and worsening renal function is also lower with ARNI as opposed to ACE inhibitors or ARBs. Hypotension, as I said, could be a treatment limiting factor. So the recommendation for Entresto is one at this particular point in time. Beta blockers, we all know, beta blockers also form part of the quadruple therapy for management of chronic cardiac failure. You all know how beta blockers work. Though we understand how they work in arrhythmias or hypertension, it's a little bit unclear how they actually work in cardiac failure. We think that they probably work in cardiac failure because they reduce sympathetic tone. Because if you were to think about it, you've got a failing heart, you've got a low ejection fraction, and you're giving them a negative inotrope. So intuitively, that shouldn't really work, but they do work because again, as we discussed earlier, the sympathetic stimulation, the high sympathetic tone in cardiac failure, chronic cardiac failure, is a detrimental part of chronic cardiac failure. Okay, so it does work because it reduces the sympathetic tone, and it is one of the pillars of cardiac failure. And the only 3 drugs amongst all the beta blockers that have been approved for cardiac failure are carvedilol, bisoprolol, and metoprolol. Okay, now we come to this big thing, SGLT1 and 2. So what are these? What are SGLT1 and 2s? These are basically transmembrane proteins which are found in the proximal convoluted tubule of the kidneys. They're found at the apical membrane, and then they work in tandem with another membrane called GLUT2, that is glucose transporter 2, and that sits on the basal membrane. So if you were to remember your glomerulus and your tubules, so you've had, say, a good meal, so your glucose goes up, all the glucose is filtered through into your glomerulus, into your proximal convoluted tubule. All of that, most of it, is then reabsorbed in the proximal convoluted tubule by SGLT2 membrane. One is not as much as 2. 2 is the predominant transmembrane protein. So you get that protein, and that then absorbs in a facilitated absorption, and absorb most of the glucose back into the system. So if your blood sugar level grows greater than, say, 180 milligrams, that is the renal threshold for glucose. If it goes above that, then you have exhausted the capacity of these transmembrane proteins, and then you have glucoseuria. So 180 milligrams is, I think, about 10 millimoles. So if you've exceeded that, that's when you will see glucoseuria. Okay, so it's, as I said, SGLT2 is responsible for 80 to 90% of the reabsorption of filtered glucose. So the way that this, I'll show it to you in the next slide. But basically, if you then were to inhibit this SGLT2 transmembrane protein, then you've got glycoseuria, and with glycoseuria, you then have osmotic diuresis and natriuresis, because the transmembrane protein is facilitated with sodium as well. So it is 1 glucose, 2 sodium ions that go across the cell into plasma. So you're inhibiting that, so you have both glucose as well as sodium going out. So you have natriuresis, you have osmotic diuresis, and this results in a reduction in blood sugars and HbA1c. So that is how they're used in diabetes. So you could then say, how is it then that they can then be they found use in the management of heart failure? So just before we go, this is just a pictorial diagram showing you how for 1 glucose, you've got 2 sodium channels going through SGLT2, and then going, they're then absorbed back into plasma. Okay, and there is the GLUT transmembrane protein. All right, so that's how they work physiologically, these transmembrane proteins. So now, for patients with type 2 diabetes, so these drugs they've been known for about 30 years, and with all the research that's been done now, they've started to use them in diabetes. And when they were doing outcome trials on these drugs, they found a huge decrease, and this was in 2013 when they came up with MPAG-REG. That is, I have to read the title of this trial. So it's empagliflozin cardiovascular outcome events trial in type 2 diabetic patients with removing excess glucose. The REG is removing excess glucose. They then found that in these patients that their all-cause mortality was low, that their cardiovascular incidence of cardiovascular deaths was low, incidence of heart failure hospitalization was low. So that then triggered all these other trials with assessing other drugs such as canagliflozin, dapagliflozin, all of these sort of things, and they've all come to similar sort of outcomes, i.e., better outcomes in the management of heart failure. So they then looked at patients with and without type 2 diabetes, and they found that there was, again, in cardiovascular deaths, rates of hospitalization for heart failure in patients with type 2 diabetes and without as well. So it seemed it did not matter if the patient is diabetic that they might be on these drugs, which is why you might find patients coming to you with dapagliflozin, fosflozin, who are not diabetic. You might find them on your in your pre-op assessments or on the ICU. Persons who are not diabetic but on these drugs, and that's the reason why they are. Okay, so it's again seen across heart failure phenotypes, where it's preserved ejection fraction or mildly reduced ejection fraction or reduced ejection fraction. And this is 13% reduction in all-cause mortality and a 25% reduction in recurrent heart failure hospitalization and CV and cardiovascular deaths. Especially, and this is in patients with reduced ejection fraction. So when you say reduced ejection fraction, that is less than 40%. Okay. So even in patients with preserved and mildly reduced ejection fraction, they were found to be effective. So they're found to be effective whether the patient is diabetic or not, and they've been found to be effective in patients where they're across the phenotypes, across heart failure phenotypes. And they've also been used now in chronic kidney disease because it seemed to improve kidney health. So that's the reason why we're now seeing this big surge in the use of these drugs. So when we looked at RAS inhibitors, that is ACE inhibitors, ARB inhibitors, or ANRIs, we've said that they all cause natriuresis and diuresis. So is that the only way that SGLT2 inhibitors work? Possibly not, because they seem to have a bigger benefit than the other drugs do, than the other drugs who cause natriuresis and diuresis. So it seems to be that they do all of that. They reduce the sympathetic nervous system, they lower your blood pressure, but they seem to be beyond all of these, and that could be one of and these are all hypotheses. They're being investigated. These hypotheses are being investigated. One of them is thought to be that with these drugs, because you've got glucosuria, your serum sugars your plasma sugars are low, and therefore your insulin levels are low as well. So which then might mean that with you become ketotic, and whether the ketones are better energy substrate for a failing myocyte, or whether they just are additional energy substrate, and whether that has an impact. So that's one hypothesis. The other one is that there is improved renal function with decreased sympathetic nervous activity that reduces renal glomerular hypertension. So the sympathetic tone is low, so renal glomerular hypertension is mitigated to some extent, and that has a positive effect on your cardiac function as well. There is an inhibition of the sodium hydrogen exchange protein, and that could mean that there is a loss of intracellular calcium, because if you remember this one, and this is the mechanism by which digoxin function, that say you're actually, when in exchange for sodium and hydrogen, you are excreting, you're actually importing calcium in. So if this is inhibited, then you're losing the intracellular calcium, and that might cause some vasodilatation. In addition to all of this, there is increased production of erythropoietin, and there's increased erythropoiesis as a result. And this could be because there is you've got all of this sugar and sodium hitting the distal convoluted tubule. That causes that there then is an attempt by the distal convoluted tubule to absorb this sodium and glucose, which increases activity there, which causes hypoxia, and that would be a trigger for erythropoietin secretion, and that causes increased red cells and that then would increase your oxygen delivery to a failing myocardium. So that again would improve your oxygen supply-demand relationship. There's also a thought that there is an antioxidant effect, and there might also be enhanced autophagy, which is basically destruction of impaired cells or impaired organelles in a cell, which has again been recognized as a cellular repair mechanism. And it might be that these drugs enhance autophagy. So all these are hypotheses, because the impact of these drugs seem to be much more than can be explained by osmotic diuresis and natriuresis and a lowering of sympathetic tone. Okay. So again, this is just a pictorial diagram of what I've just described. So applications of SGLT2, again, so you can use it. They are one recommendation, recommendation 1 for reduced cardiac function, reduced ejection fraction heart failure. They are again for mildly reduced and preserved cardiac function. They are type 1 recommendation, class 1 recommendation, again recommended for type 2 diabetes and in chronic kidney disease as well. Okay. Now, with this, and this is where our, you know, we have had conflicting advice being given to us by various pharmacological, you know, bodies telling us, trying to give us advice on whether we stop them perioperatively or when they're on ICU with sepsis or, say, critical illness, or whether we continue them, because the issues with some of them, really, with all of them, to be honest, is that you can get ketoacidosis, as we discussed. And this could be, as you know, marked. So you might get euglycemic ketoacidosis when oral intake is low during intercurrent illness, sepsis, periop periods. You know, we see that a bit in our on the cardiac ICU, where you have patients coming through who are mostly on dapagliflozin, and I still can't say the names of those drugs. And you find that they are ketotic, but the sugars are normal, and they then become acidotic, and you're not really sure what to do with that. So from the ESC guidelines, the guidance there is to stop 24 hours pre-op when oral intake is low, and then to stop at, you know, and restart them, say, 24 to 48 hours after oral intake. It has, you know, optimized when they're back into the full oral diet. To stop during critical illness and sepsis, and also part of the problem is likely to be volume depletion. So consider giving them fluids, and this is particularly true if the patient's on the unit with diarrhea, with, you know, so the loss of fluids is going to be even more significant. One that is born through over time are genital mycotic infections. So that does happen, and that will need to be addressed. Very rarely you can get perineal Fournier's gangrene. Okay, so these are the perioperative concerns as far as SGLT2 inhibitors are concerned. Now, so we've talked about the 4 pillars. Now we come to the other drugs that might be started on certain patients, and we'll just have a quick look through them. Now, this is ivabradine, and this drug reduces heart rate. How does it reduce heart rate? It does not act on beta receptors. It acts on the slow, the depolarization, the slow depolarization of phase 4. So phase 4, and it works on SA node. It doesn't work on any other part of the conducting system. It works only on SA node, or AV node. So other than the SA node and the AV node, the rest of the conduction pathway, because the action potentials there are different, it doesn't work on those. So basically, it's during phase 4 depolarization, there is a slow influx of sodium initially. So when your membrane potential is about -60, you have this slow trickling in of sodium. And then when it gets to about, say, -50 or so, you then have some calcium channels opening up. And when it gets down to between -40 and -30, you have further calcium, long-lasting calcium channels open up. And then you have this big spurt, you get the trigger, and then you have the big spurt, you get the depolarization curve. And then you have phase 3, where potassium starts to leave the cell. And then you have that long dip into to -60, and then you have the slow depolarization start again. So this is all, guys who are going to be sitting the primary. This you will be expected to know all of this, okay? A bit traumatic, but you'll be expected to know this. So what then happens with ivabradine? Acts on these slow channels, the slow sodium channels. So because it acts on the slow sodium channels, it slows the diastolic depolarization and hence SA node firing and heart rate. There's no effect on blood pressure. There's no effect on intracardiac conductivity and contractility. So if you're looking to just reduce heart rate, this is actually quite an attractive option. Having said that, and if you were to then reduce your heart rate, then you're improving your diastolic filling, you're improving your oxygen supply demand balance. So all of that would then help with cardiac failure. But having said that, it hasn't really stood much scrutiny in terms of the trials that were conducted, and I'll come to that in a bit. But generally, the slide is talking first about contraindication caution, so we'll talk about that first. So contraindications, if you were to look at the way it is working, a sick sinus syndrome, you would not want to use this because you're probably needing pacemakers rather than slowing of heart rate. Complete heart block, sinoatrial block, unless these patients have been fitted with pacemakers. But if they've been fitted with pacemakers, they wouldn't have, they wouldn't need ivabradine because the intrinsic heart rate is going to be quite slow. You're not going to be giving it in acute decompensated heart failure because you wouldn't be able to control the heart rate, and you wouldn't want to reduce the heart rate in some situations. Severe hepatic dysfunction, decompensation, or you would not want to use these drugs if they are, because this drug is metabolized by CYP3A4. So any potent inhibitors of this CYP, you would not want to use that because that would then mean you would have ivabradine toxicity. And drugs would include things like some antifungals like itraconazole. You would want macrolide antibiotics like Clary or antiretrovirals. You would use them with a little bit of caution, with significant caution, I would assume, if they are moderate CYP inhibitors, in the presence of moderate CYP inhibitors such as diltiazem and verapamil. Both these drugs are not that often used nowadays anyway. But drugs such as, say, CYP inducers such as rifampicin or phenytoin or St. John's wort, you would want to use, again, exercise caution if you were to use these things, okay? So again, as I mentioned earlier, ivermectin hasn't really stood up to scrutiny. So it was based on 3 trials. One is called Beautiful, Shift, and Signify. Shift is the only trial that actually improved the rates of cardiovascular deaths and heart failure hospitalization. The other 2 were did not demonstrate similar improvement. So in terms of European Society and AHA and ACC guidance, this is a class 2A recommendation, and it may be considered in patients with ejection fractions lower than 35% and resting heart rates greater than 70. And if they're then, only if they're on maximal beta blocker therapy or they haven't tolerated beta blockers. Okay. So this is a novel drug, which is also been recommended by both ESC and the American societies. And this is called vericiguat. Not sure if I'm saying it correctly, but I'm just saying it as it is written. So it's basically a soluble guanylate cyclase stimulator. So again, for those of you who are going to be sitting the primary, you will need to know this stuff, which is basically nitric oxide. It's an ubiquitous molecule in the body. It's present everywhere. Now, this is produced by 3 enzymes from L-arginine, okay, amino acid. So it's by endothelial nitric oxide synthase, which is the one that physiological, and the other 2 being neuronal and inducible isoforms. So in sepsis, where you have vasodilatation, it is the inducible form of nitric oxide that is present and causes that uncontrolled vasodilatation, where you have that massive loss of vascular tone. So what nitric oxide then does is it diffuses into vascular smooth muscles. It catalyzes conversion of GTP to cyclic GMP. Remember, we spoke about this with natriuretic peptides as well. And the cyclic GMP is a second messenger. It activates protein kinase G. That then causes vasodilatation, inhibition, smoother muscle relaxation, vasodilatation, reduction in inflammation, and improvement in cardiac remodeling. So in heart failure, this pathway is impaired. And vericiguat is a soluble guanylate cyclase stimulator, which would then try to restore this pathway. The recommendation for this, indication for this is if there is worsening heart failure, they are on the 4 guideline-directed medical therapy, the quadruple guideline-directed medical therapy, or that is optimized, or they're unable to tolerate the quadruple therapy, in which case you might want to add vericiguat, and the levels of recommendation is 2B. Okay, so so you may use it if you are in this sort of a position. It is not fully recommended. But there are ongoing trials with this. Okay, so I've just put in a couple of slides for the ESC guidelines for reduced ejection fraction, which basically is the 4 pillars that you have of drug therapy. And then they talk about if you are in AF, you will want to you will need to anticoagulate them, anticoagulation for AF. You would want to either do, you might want to do pulmonary vein isolation if you want to get rate control and rhythm control. CRT if you are having low ejection fraction and you're not controlled on the 4 drug therapies. Then there's talk about, iron therapy for those patients who are anemic to help with the oxygen supply demand. So there's a bunch of things over there that they then recommend. Okay. And this is for mildly reduced and preserved ejection fraction. Pretty much what we just discussed. And this is just an overview of the 4 pillars of drug therapy with other bits and bobs added to it, which we did not talk about today. Any questions, guys? Or did I not make any sense at all?
Rajni, looking at the gliflozins of this world,
Yeah.
do you see a role for them in the restorative period on intensive care for patients who are over the acute phase and are starting to get better, those ones that usually have a bit of renal dysfunction, maybe a bit of fluid overload?
There is talk about that, Mike. There is talk about, and there are a few studies coming through as well. So there's talk about adding flozins after an MI, an acute MI. So once the initial phase is I think sorted, they're even talking about starting it within about 48 hours of an MI. And there is talk about using them in acute decompensated cardiac failure as well, but the evidence is still not out. So yeah, you can use them with caution, I guess, because you should be able to, because again, I know our units are slightly different, but most of our patients are fluid overloaded by day 3. So, it would be a good diuretic. There would be good diuretics. And yes, as long as you were to understand what that ketoacidosis is about, and if they do, and you then manage it with your, calorie intake.
That's the one. Thanks, everyone.
Thanks, everybody. Thanks for coming today.